Hello, everybody. Thank you for coming back after the break. That's always exciting. We're going to talk today about the role of medication in crisis care. And I want to introduce my colleagues, Dr. Rob Cotes, who is an associate professor in the Department of Psychiatry at Emory in Atlanta and also part of SMI Advisor. And then also Dr. Chuck Browning, who is the CMO at RI International. And we were really brought together as we were starting to think about 988. And as we had the pleasure of working with NASMHPD, SAMHSA, and RI International on the 988 Crisis Jam, we began to see a lot of questions coming through about, but what about medication during the crisis? And how do you handle that? And there are a lot of barriers and a lot of questions, and people are in a rush. And so we wanted to bring to you today a discussion between Chuck and Rob about many of the issues in that moment of crisis around medication. And they're going to talk for about 35 minutes. I'm going to talk for maybe 7-8 minutes afterwards about some resources we have to use to support your systems during that moment. And then we'll have a few minutes for questions at the end if everything goes perfectly. And so I introduce Rob and Chuck.
So, Rob, the first joke and observation I'm going to make, we work in crisis and receiving centers, and when it is time for, you have medication passes, times a day where you give out meds, and it kind of gets notified, and the room kind of empties out sort of like this when we do it. So we're waiting for people to come back in.
Yeah, thanks, Chuck. And I apologize to this side of the room. We're going to kind of be having a conversation with each other, and I'm going to be turned over here. So nothing personal over there. Anyway, we're really grateful to have this conversation really for the third time. The first time that we had this, a talk that was similar to this was on a 988 call a couple of months back. And then the second time was on an SMI Advisor webinar where Chuck and I got together with Pat Deegan and with Lisa St. George and had a really interesting conversation. So, the voice of lived experience is missing from this panel, but I think the spirit of lived experience is most certainly here, and we're going to be talking about how individuals with lived experience can help to, influence all sort of aspects of this conversation. So we don't have slides, but what I want to do is give you a quick overview of what we're going to talk about. So first, Chuck is going to give us a bit of a framework of the what, the why, and the how regarding medications in crisis care. And then we're going to talk about some more specific situations, maybe about medication in early psychosis, then a little bit about Clozapine, and then some about long-acting injectables. And then finally, we might talk a little bit about the SMART tool, which was recently developed by the AACP, and I'm really excited to bring that discussion here for us today. So, maybe to go ahead and get started, Chuck, do you want to tell us, a little bit about, the why? Why do we need medication?
Great question, Rob. So the why, in essence, if you think about our core services that we've been talking about related to 988 and then having mobile support teams and then having a place that when people do need it, a place to go. And if these places, and Margie mentioned this, and when we talked about what do you hope for in 5 years discussion in the panel about the hope and the things that keep her up at night is, are we going to be able to manage all the acuities and serve everyone and have access within the infrastructure of our crisis receiving centers to be able to say yes? And so we hear about no wrong door. I like to always twist it around and say, teach our staff it's not just a no wrong door, it's also always find ways to say yes to create access to care. So having medications as a tool, it's not the only tool at a crisis receiving center, but it's a really important tool to be able to say yes. And then the second piece is it's also a really important tool in terms of just having that in your armament of things that you can offer people for best care based on the certain situations that you have. So when you think about the why and how you need to create that so you can say yes, it gets a little bit more complex if you think about all the different situations that show up in a crisis center. It's everything. So you have people coming in with challenges with depression, mania, or aspects of bipolar disorder, substance use, whether it's intoxication, withdrawal, or just seeking treatment for that, having concerns with psychosis. So there's just a plethora of different things that you have to be equipped in your infrastructure if you need that as a tool. And then there's so many things that we do in treatment for folks separate from medications, but medications oftentimes can be a really big help for immediate relief of certain symptoms, and sometimes our best care and best practice. So that's the why.
Okay.
Is both creating access so that you can say yes, but then the second part is to give the best care as well.
Gotcha. Can we break down a little bit more about the what?
Yes. So when you look at those situations that I'm describing, you got to think about what do you need to be able to do that. And so at its base, for the mental health things, you need to be able to have access to certain types of antipsychotics, medications to help people stabilize their mood, medications to help with anxiety, medications to potentially start people for depression. Oftentimes, acute deprivation of sleep and the stress about that is important. Medications to help with side effects of other medicines, which is a whole other thing that gets into the tension about medication and their role in crises, dealing with side effects that sometimes can be very distressing and part of crisis. You need to have medications to help manage withdrawal symptoms of substance use, which sometimes can be dangerous or life-threatening, and that if you don't have them in a crisis center, you have to send somebody to the emergency department. Then you have to have medicines to help with withdrawal management. Agitation is a big one because, again, sometimes if you're really serving everyone, you might have people who are not happy to be there and are really struggling with symptoms. And even when you're being caring and connecting and engaging with them, they may, suddenly punch someone or go after harming themselves. And so you have to be able to have medications to help support folks for those needs. Referencing Margie, one of my favorite slides that she has in her discussion is about a particular medication that we don't think about when we think about medications in a crisis center, but it's really important. Can you describe that slide, Rob? I love that. Or the study, the study that we're talking about.
Well, Margie can take credit for this, but really one of the things that helps agitation management the most is just doing something simple like adding a nicotine patch for someone, and really sort of go ahead.
Oh yeah, so the cool thing about the slide is it's a guessing game. It's got different medications and watching agitation scores go down after time, and you have to guess what medication is the magic thing in dealing with these folks with agitation. And the answer and the punchline is that flashes up on the slide is nicotine. So it's a really important thing in your systems to think about. Is you're going to have a lot of folks, and almost everyone would be a non-smoking facility now, so you need to be able to support that. In terms of best care, where we talked about having best care, so having medicines that match up with those things, but thinking about opiate use disorder and MAT with alcohol use disorder, having access and immediate access in a crisis situation, just like we're doing now with inductions in emergency departments and things like that, to be able to have best practices to connect people for that as well.
So Chuck, one thing that you were telling me earlier today that I was absolutely blown away by and I didn't know is that over half of people who actually work at RI International have a lived experience of some sort. And I'm wondering if in the discussion about how should we use medication, we can talk a little bit about that, sort of bringing in the perspective of lived experience into that.
It is, and that's what was so special about our webinar that was really cool to be able to have Dr. Deegan and Lisa St. George talk about their experiences of dealing with medications, especially in the context of when they were in crisis, and their experience of the dynamics and the interaction in the system about medication. And we talked a lot in our panel up here on Sunday night about using lived experience to shape the way that we do things. And between tools and things that Dr. Deegan has outlined, the SMART tool, which we're going to get into, really important message. I can't say enough about the importance when we talk about how to do this, that we're not at that 5-year point looking back and saying we missed the mark on starting at the beginning and looking at those systems and educating our providers about how we do these things to not incorporate some of those concepts. So would you like me to talk about some of the concepts?
Absolutely.
So I'm going to do my best to do justice and include some of the things that Dr. Deegan and Lisa pointed out in summarizing this. But if you wanted to get a much deeper dive, seeing the webinar online is a really cool experience to hear it from their words of it. One of the concepts I think that's really important is collaboration. So Dr. Deegan really talks about that shared decision making, and that there are two experts at the table. The person who is the expert on the knowledge and information and education about a medication, what it potentially can do, its risks and its side effects, and be able to give that information to the person that you're working with and that's being served. But then that person is the expert on themselves and what what they've taken before, what's worked, what hasn't worked, what they're willing to do, what they're not willing to do, what is the role of medication in their life and how they see it. So all these elements are in place in this situation when you're working with someone as a provider. And one of the things that in working with a group where we have such a strong lived experience, giving voice to thinking about those kinds of things, is creating a dynamic where you can be more aware of the power differential that's just built into crisis situations. So people come in to a facility oftentimes against their will on involuntary commitment and whatever the rules are in that state. And there's a pressure that if I do what these folks tell me to do, then I get to get out of here. And so it creates a power differential that's really present between the provider and the person being served. And so it's really important to try to break that away so that you can have a shared decision-making discussion, even in that context. And that, it's not taking medicines that get you off of involuntary commitment. It's just this thing that was happening that was unsafe that we need to work towards that. And medicine may be a tool to help that. And it's a decision and a partnership together. But there's a lot of pressure on that. And our providers and our systems need to be aware of that dynamic so that we can be open to addressing it, clearing that out, so that then that person is going to be much more likely to be in charge and empowered on their journey in recovery to use medication in that. So that's one key thing, is do things with people, not to them. Second common concept that comes up is this recovery-oriented approach. And so thinking about that, while medication can be important and a diagnosis can help guide that information, it is not the end-all and be-all in crisis. There are so many other social determinants and other things going on in 95% of these crisis situations that happen that need to be addressed and are important to be addressed. So medication is important, but if you make that the only focus as a provider of talking to the person, here's your diagnosis, here's the symptoms that are going on, this is what we're going to do for it, in that kind of pejorative way, without thinking about things like meaning and purpose and social determinants and supports that person has with their family, those kinds of things. What kind of interest and motivational stage are you in terms of being ready to do things? All of those got to be put in the piece together to really have an ideal chance to maximize how medication will play into that part. A third thing is inclusivity, which is part of we teach that in part of our trauma-informed care principles, but it's looking at the role of that person's, where they are, their race, gender, folks with IDD. There's so many different situations that as we design these systems, we need to think about, how does that impact and how is it perceived differently? What are issues with medication in one culture that might be different than another, and have an awareness and cultural competence to be able to do a better job of that. And we're going to get into some details as we talk about systems and the SMART tool, which is a tool designed to help organize and look at how you can self-modify and work on anti-racism tools within your systems, and they actually apply to certain medication issues. And then I guess finally, in a last piece of thinking about that macro approach is separate from the lived experience push, but going back to the medical clinical research, is that we are not where emergency medicine is now in the standardized understanding of what works best in what situation for everything. There are studies out there that guide us in lots of information, but as we start this journey of a standardized crisis system all over the country, we need to have systems in place to share data, what works, what doesn't work, publications about that when you do use medications, here's guides like we have for cardiac disease and strokes and things like that in emergency situations.
Yeah, a lot of great points. I was really struck by what you said about the power differential, and I guess I'm wondering if you may be able to speak a little bit more about that, about ways that we can kind of continue to mitigate that. And I guess I sometimes wonder if there's ever a role for, for people on the team to sort of mention this directly and, sort of speak to this issue in a more of a explicit rather than an implicit way.
Yeah, I think definitely addressing it directly. For us, one of the best tools that we have is a significant use of peer support. And so there is nothing that helps engagement and connection for us in the fact that a lot of times as a team, our peers are part of the team, not encouraging medication or discouraging medication, but just being open in our crisis dynamic of the things that we do. This is a tool. Would you like any help in how to talk to the provider about it? It's really important in encouraging the person to share, to use those practices of collaboration. Say, it's going to be okay for you to talk about what you don't like about this or have liked about this. And so I think the use of peer support it is a clinical situation. It's not a licensed clinical situation, but it is a very powerful tool in improving communication and engagement.
You know, my mind is actually taken to an intervention that we did at Grady Hospital in Atlanta, where we were looking at a Finnish idea called open dialogue and dialogic practice. And what was interesting about this was we had these meetings with people and with their networks, and we actually opened up a space for people to talk about and to metabolize sort of what happened with them when they were perhaps in a crisis, when they were on an inpatient unit, and sort of talking about, the perception of coercion, sometimes coercion directly, and just sort of offering these spaces in order for people to be able to talk about it. And I was really surprised when we actually opened the door for some of these for some of this communication, because I thought that we were doing everything that we can as a system to sort of mitigate these things. But it's sort of interesting what you find sometimes when you open the door.
And in crisis care, the person that you're seeing at the first 15 minutes that comes in the door and the things that they're going through in that crisis can be vastly different 8 hours later, after some sleep, food, a shower, having a sense of things. And things can change rapidly in terms of someone's openness or lack of openness. So the way you treat people, and a lot of times the provider is the last person to see. So someone may have done a nursing assessment and a clinical assessment and these other things. So I think your system and how you pull together the customer experience for the person can have a big effect by the time the provider gets there as to helping it be ready and a good expectation about what to expect, or, oh my gosh, I cannot believe I have to do this again. And the frustration and just feeling, this is not a great experience.
Yeah, you make a very interesting point about how in crisis care, the situation may evolve very quickly and may change very rapidly. And I think that from a sort of prescriber standpoint, there's clearly two experts in the room when we're talking about medication. And sometimes on the prescriber side, we may be able to talk about, some additional concepts that somebody might not know about, like the side effects of medicines. And sometimes in these crisis settings, we may have to have an openness to, maybe go back and have some of these conversations. Maybe sometimes it wasn't the right time to have a particular conversation. So I think I like that point about how things can evolve, and we need to be present with people where they are about some of these conversations.
And I'll say one more thing that just popped to my head that was not featured in any of our other talks before is the role of a provider in a team and how that impacts the role of medications in a crisis situation. If someone is struggling with psychosis and is really scary to other staff on a unit, there can be pressure on the provider from a nurse or from a clinician or from a peer to say, you need to get some medicine in this person. And it becomes quickly away from collaboration and more of a coercion type thing. So some of the things that we're going to talk about specifics when we get into prescribing of antipsychotics and some of those things, it's really great for the provider to take a lead with the team in educating about the pros and cons of certain things, how to approach that dynamic, and taking the lead with helping with fear. And it's a constant tension of those types of situations when you are dealing with the higher acuity situations by saying yes to everyone.
Mm-hmm. I also was thinking that, from a policy standpoint, it's really helpful when the entire team and when the entire system is on the same page with what's the policy for involuntary medication, because that's an issue that is obviously a last resort, but sometimes people are doing things that are rather unsafe. And there needs to be sort of a shared understanding of when one might have to try something like involuntary medication. Sometimes I've seen it where people may apply different criteria in sort of different ways, and sometimes it helps when the system is all on the same page about that.
And we're going to get into tools, and that's one of the things I would encourage all of the states to have that you're having an ability to measure outcomes, is to look at forced medication events, the numbers of it trending up, trending down, where does it stack up in terms of what makes sense in a typical higher acuity environment, and then the constant push, just like with seclusion and restraint, to make that a only under the circumstances of immediate or imminent danger and no other circumstances, because it's so easy for it to slip over that line and for staff to do that. And so some of the things policy-wise that can make a difference on that is, do you have standing, do you allow some kind of like standing emergency orders so that the nurse doesn't have to talk with the provider first and can activate that under circumstances, or not, so that there's always that expertise in that decision. So those are some of the things that you see providers making decisions on how those go. And then sometimes it is regulated by state law, what you can do or not do in that.
Yeah. Good points. I wonder if maybe we can pivot to some more specific sort of situations, and maybe we can talk, maybe a little bit about early psychosis.
I'd love to hear your expertise in this.
All right, so just to give you all some background, I work at and I direct a coordinated specialty care team for people with early psychosis in Atlanta, Georgia, called Project Arrow. It's one of the SAMHSA-funded programs in the state through the light ETP programs. And, I think that when we're considering individuals with early psychosis and the use of medication, the stakes are high. That's the first thing that I'm thinking. I think the interaction with the crisis system often dictates the tone for how someone's experience will be with the mental health system. And, a positive first impression, I think, can really help with the engagement process. One thing that we do in CSC teams is it's engagement, 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 engagement. This is not a model where people say, oh, I have something that I need help for. The onus is on us to help to engage people with early psychosis and help to communicate what we can do, and help to communicate, more importantly, that we can partner with them to help them accomplish their goals. So I think that from a conceptual framework, medication is often embedded into this idea in a recovery-oriented way of helping people to accomplish their goals rather than sort of ameliorating some sort of symptom. That is important for some people, but I think that this return to function is a really important concept. Improvement in relationships, getting back to school. And then, before we even get too far into the pharmacology, I think it's really important to mention coordinated specialty care in general for people with early psychosis. So if somebody has early psychosis, I wonder, could they be connected to a CSC team? Are they already connected to a CSC team? I'm often looking at the sort of SAMHSA treatment locators or the resources in PEPNet to see if there's an early psychosis team that might be able to work with somebody. If somebody is with an early psychosis team, it's so important to reach out to them, because they know that person often really, really well. They can even maybe come to the area where someone's being seen for crisis care, and there can often be a lot of really nice dialogue. The principles themselves for the pharmacology for working with early psychosis folks is really, it's pretty straightforward, but I think that it often applies for people more broadly than that. Generally speaking, 1/3 to half of the dose for antipsychotic medications is often helpful for people in an early psychosis setting. And in crisis settings, what we typically see is that when PRN medications are scheduled, that's the as-needed medications, like if someone has to have an injection of medicine, we have to be very intentional about dialing back the dose and using much lower doses, because people can, who've never had one of these medicines before, it can get sedating, people get knocked out, makes people feel like crap. So reducing the doses is extremely, extremely important. We talk to our residents at Emory about this all the time. Make sure you have an individualized plan for the person that you're working with. There's a benefit to standing orders and having a system in place, but especially for early psychosis folks, these lower doses are extremely, extremely important. The other thing that's important to talk about is, how are we presenting a medicine as a system? What kind of conversations are we having about this? And one of the most important things is to be honest and upfront with people about why we're using this. I've seen so many times people will say, oh, we're using this medicine to help you sleep or to help you calm down. And this is one of the kind of problems that can erode the trust, I think, with the system. If we're not upfront and honest and saying, like, let's talk about, what's happening, what kind of feelings are you having? Can we use a medicine to help people feel less afraid or less paranoid, or maybe it might help with the voices? And then very early on, having a conversation about what are the potential adverse effects to these medications in a very open and honest way. And then, of course, in the early psychosis stage specifically, we're thinking about medicines that have a lower cardiometabolic side effect profile. So using medicines like, Longacting, for example, that may cause weight gain in early psychosis is probably not the best idea. And we already know that people with early psychosis have, cardiometabolic problems to begin with, even before they are prescribed a medicine, perhaps as a result of, what might be going on, neurobiologically. So I guess a couple of other thoughts I have about this is, providing options. I think that in a crisis setting, sometimes I see people saying, one option. Let's try this one medicine, and what do you think about that? I often find it really helpful to present different options, like at least 2 options. You don't want to present 6 options. I mean, I'd love to present 6 options and talk about all sorts of different side effects. And it's like it's too much when somebody's going through a lot. But if you can talk about 2 options, that can really help, I think. And people can make a really informed decision about what they would prefer to try. And then, of course, telling people to pay attention to what they're experiencing, pay attention to their bodies. Like, if you have side effects, tell us. We don't want this to be something where something happens and you don't know about it, and then you're like, what's going on? I remember in the panel, one of our panelists was talking about not even knowing the way that she was feeling was a potential side effect of the medicine, and she was left with this question in her mind. And it just seems like that's a failure on us as a system to not kind of make sure that people know what they're getting into.
And one other concept of early psychosis that we've talked about that I think Dr. Deegan does such a great job describing in her medication empowerment series is, especially in crisis, a medication choice is just a part of your journey in recovery at that moment. It doesn't mean that you have to commit to be on medications for the next 30 years. And so thinking about medication as a journey, creating that system and discussing it in that way, and both the pros and cons of stopping too soon and what data may show on certain things of that nature, but being able to discuss it is a really important concept. You did bring up cardiometabolic, which reminded me, I thought of one other what medication that you need to have, which is people are going to come in, and if they're staying in a short-term unit, or if they need to be able to be there safely with you and have medical issues, is you have to have some basic medications in your system to manage blood pressure, diabetes, skin infections, basic antibiotics, things like that. So that's just another thing that if you've got to build it into your infrastructure so you can say yes.
Mm-hmm. Yeah, I think that's a great point. The other thing I wanted to talk about real quickly about early psychosis is in a crisis setting, sometimes people may develop catatonia. And this can be a challenge, I think, for the health system because, there's a couple different ways that catatonia may happen. It might happen to around 12% of people with early psychosis. But when it happens, it can often affect length of stay. And it can affect sort of what happens next for people. And, catatonia may be an extreme manifestation of depression, mania, psychosis, a medical issue, and it does not necessarily equal schizophrenia. So in the management of catatonia, one of the most remarkable sort of pharmacologic things we have in psychiatry is when somebody responds to a benzodiazepine and they no longer have symptoms of catatonia. It's a rapid turnaround. But then the question is, well, what do you do with these benzodiazepines? Do you discharge them with the benzodiazepines? What if they have a substance use disorder? Do you give them the benzodiazepines? What do you do with the antipsychotic medication? And it leads to a lot of questions that can be difficult, and often people have highly individualized strategies of trying to help with this problem. So I guess I want to kind of raise some awareness to catatonia and encourage systems to think about this because actually in an analysis that we did at Grady Hospital, some of the longest length of stay individuals that we were working with had sort of refractory catatonia.
Yeah. And leading into that particular specific thing, when you're looking at systems and how you design your systems, one really important thing that's even in a greater dynamic about medication is a crisis center is a moment in time that gives you an opportunity to really engage with that person and connect with them in their whole health. And so helping people who a lot of times show up and haven't treated something medical for years and getting them connected and engaged in their whole health on taking care of certain things like that. But then it's that next step for both their physical health and their mental health or substance use things how is that system designed to connect from crisis into recovery and support that next piece? And that's really important in medications. So one of the things thinking about is how can you make it as easy as possible for that person to get follow-up very quickly, both for their whole health needs, as well as can you set up a system where you're prescribing and getting them medications to walk out the door with so they have it and don't have to go to a pharmacy, because that's an unbelievable barrier for sometimes for people who are in crisis, who may not have any money at all to be able to go to the pharmacy to pick something up. So having things in that system to take out barriers to make it easier to stay in some kind of treatment that makes sense and is best practice.
Sounds good. You know, Chuck, I want to talk about Clozapine. I think we should talk about Clozapine for a moment, and I think that there's a lot of things that systems can do to help support Clozapine's use. So everyone, I think, is aware of the problem. 4 to 5% of people in the United States with schizophrenia are prescribed Clozapine. Clozapine is the only FDA-approved medication for people with treatment-resistant schizophrenia, and probably between 20 to 25% of people have treatment-resistant schizophrenia. So there's a significant underutilization of Clozapine in the United States that we, I think, as a system really have to think about what can we do to move the needle here. And there's a great opportunity, I think, when people are presenting in a crisis to be able to think about Clozapine in those particular settings. Because I think that in crisis, there's a unique vantage point, because you can kind of tell if somebody has been taking medication. Are they having breakthrough symptoms from their current medication? Is it a medication consistency issue? Are they not taking medication? So I think that the crisis setting can be a really important way to identify potential Clozapine candidates, and just sort of putting that thought on a piece of paper. Somebody else might read that and say, okay, maybe we need to start thinking about Clozapine for this person.
It's got a lot of layers to it, Rob, because there's barriers in the system to make that happen. There are, you have to have your staff having access and trained and signed up to the Clozapine REMS system. They have to understand how to prescribe it, how to deal with it. If you're in a crisis situation and doing that, I love in the webinar your discussion about people who are already on Clozapine and some of the things you may see and things you need to know to safely restart them or deal with symptoms that they may have if they had a sudden stoppage of that. The other piece is thinking about barriers in connecting that person to next steps. So this is kind of bleed into your talk about long-acting injectables, but there are oftentimes, is that person going to be able to get connected to the right engagement and resources in their follow-up journey to do the weekly labs once they're getting started on it, to be able to go get that done, to consistently take oral medications. And yet sometimes that population is the folks who would really benefit from the most, and what kinds of ways can we continue to adapt the system to make it easier to help them have access and be able to benefit from it.
Yeah, I mean, I think that one of the things that I've seen sort of as an inpatient psychiatrist, as an outpatient psychiatrist, I find myself more effective the more I know about the community and the community resources. And, I think that especially early in my career, I would just go to different places and meet with different people and form relationships and know who was, maybe a buprenorphine prescriber, or know where you could get a long-acting injectable for somebody, who the other Clozapine prescribers were in that particular area. So, developing, I think, these sort of comprehensive resource lists, maybe being able to look at, SAMHSA locator who can provide some of these evidence-based practices, I think is really important.
Agreed. Our time is starting to come close, but I was going to see if you could just really quick talk about long-acting injectables in the context of crisis. Okay.
Yeah, I mean, there's two main issues. I think the first issue is, what if somebody is already on a long-acting injectable? And then the second issue is about identifying people who may benefit from a long-acting injectable. And from a conceptual framework, it's all about, we do this a lot with early psychosis folks, is normalizing the use of a long-acting injectable and making it just another option that people can, potentially try, rather than saying until somebody has failed or until somebody has stopped taking medicine, long-acting injectables are just another way the medicine comes. And I think having that framework can really help. The discussion about a long-acting injectable is often really, really important in a crisis setting about how that is. People need to know, about the loading dose schedule, if that's something. They need to know about the oral bridge period. They need to know how often they're getting it. Long-acting injectables these days can be between 2 weeks to 6 months. There's a lot of different types of long-acting injectables. Long-acting injectables also bring about a lot of system challenges in terms of how to actually obtain them and then how to actually administer them sometimes. And some paying for them can also be challenging.
Classic situation, you have somebody on a long-acting injectable, they've already had it filled by their ACT team, the ACT team has access to the medication, they're in your crisis center, you want to give it to them, and there's different rules and regulations of how do you get that medication brought in, or if you want to get into the insurance, their Medicaid is already paid for it for that month. So in your systems, thinking about how to help for those populations being able to get access to it is important. I've got like 10 more minutes of stuff to talk about our time, friend.
It's always a privilege to listen to the two of you, and I think mostly because I know the passion you have for this topic. And so I feel bad cutting you off. Not that bad. I also wanted to thank NASMHPD and the team for seeing the value in this topic. It's something that we feel is our little slice in the 988 crisis continuum that we're building, all of us across this country. And so if there are more questions about the role of medication during crisis care, I hope that we find a time to connect and to give you more information about that. I'm going to just take a few minutes to roll through some very concrete resources that you can take back to your state. And I just will start by saying, and it's okay if you don't raise your hand, who in this room has heard of SMI Advisor? Like, heard of it? Oh, pretty good. Keep your hand up if you've actually visited our website. Woo, not an SMI Advisor naive group, so that's good. Let me just roll through a few things, a little bit about SMI Advisor. So as you know, SMI Advisor is also called the Clinical Support System for Serious Mental Illness. We're funded by SAMHSA, and we sit at the American Psychiatric Association. We are a national initiative and serving the mental health care team. The mental health care team caring for those with serious mental illness, as defined by SAMHSA as including schizophrenia, bipolar disorder, major depression. So thank you for visiting our website where all of our assets sit. We've had over 1.5 million visits to our website, and we hope that you will visit over and over again. We hold everything there, and again, everything that I'm going to show you today and everything involved in SMI Advisor is free. We really offer three things to the clinical team. One is education on evidence-based practices. Another is vetted resources. I'm going to talk about what vetting means in a second. And also direct consultation to clinicians. We're one of the only SAMHSA centers that actually do one-on-one consultation. So you can write into us and we will answer you within 1 day during the work week. So in terms of our education catalog, we have over 400 pieces in our education catalog currently. So that includes 43 live webinars a year, so almost one every week. Plus we also do deep dive virtual learning collaboratives where we have small cohorts gather together over 12 weeks to really work on something in depth. Now, what's important about the catalog is that everything offers free CME. And when appropriate, it also offers free CE for psychologists, free CE for social workers, and free nursing credits. So we're getting at the whole team and helping them learn together on a specific topic. We have over 1,100 evidence-based resources in our knowledge base. And I sort of spoke earlier about vetted knowledge base. Anybody in here, and maybe some of you are doing it now, searching the web on a topic you're interested in. Any of us could do that. You're interested in CBT for psychosis? You Google it, right? What we do is we work with our partners, NASMHPD, NRI, RI International, TAC, anybody, who sends us what they think are strong resources. We then take two clinical experts who are experts in the topic to independently review the resource. Is it applicable to frontline clinicians? Is it applicable to the population with SMI? And does it have the most recent evidence base? If it passes those three by both of the reviewers, it goes into the knowledge base. So consider next time when you're thinking about searching on a topic, come to SMI Advisor because we've done sort of the groundwork for you already. Here are just two recent that have been added to our knowledge base. One, a guide on suicide and SMI that we did with the Suicide Prevention Resource Center. And then also, when you visit our website, you'll see there's a tile to also enter as an individual or family member. And I would encourage your providers to also go to that side because there are a lot of things over there that are good handouts, testimonials, and a lot of hope on that side, which is really important for individuals and families. Lastly, I mentioned consultations. We have consultations, again, on any topic, and someone answers within 24 hours. Now, here's a word cloud. We've done over 3,000 consultations in the first 4 years of our existence. You'll see psychopharmacology is the biggest one there. That's really for two reasons. Psychiatrists are very comfortable with the idea of consultation. Consultation liaison is something that they learn about and they use all through their training. Social workers, psychologists, peer specialists, not so used to doing consultation, but it's growing, and we encourage everybody on the clinical team to use the consultation service that we have. I want to just roll through a couple centers of excellence we have. One on Clozapine, which Rob leads, and also we have one on long-acting injectables, which is led by Rob and our nurse practitioner. What I would say about these Center of Excellence is it groups together tips and resources on these two topics, which we want to make it easy for people to find things about these two centers. When you go to our website and you go in as a clinician, on the top nav you'll see the centers, and you can pull it down and go straight to our long-acting injectables Clozapine Center. We have a very active listserv, and I know what you're thinking. I don't want to be on one more listserv, right? You probably have a folder like I do, is how to unsubscribe from all my listservs, okay? But I would say this one's a good one for your folks who are using Clozapine and long-acting injectables regularly. Very active discussion, keeps them up on the most recent evidence, and with tricky cases, it's the place to go to get input very quickly. It's moderated. So we found early on that we weren't moderating it, and some people were coming up with some things that we didn't feel comfortable as evidence-based. Now it's moderated. So everything in there you can trust that someone's looked at and feels comfortable with sharing that kind of guidance. Just a last couple things. SMI Advisor has developed an app. We have an app that's our website on an app, so you can always download that free, Android and iPhone. But we also have an app called My Mental Health Crisis Plan, which is a way for an individual or a facilitator to help someone develop a psychiatric advance directive. You may have strong feelings about psychiatric advance directives, but just as we talked about today, it's a tool in the toolbox for your individuals with serious mental illness that may be really helpful to the team in the moment of crisis. What I love about our app is the information is not held in the app or in the cloud. It's only on that person's device, and they choose who they want to share it with. Use the native functions of the app. I can share it with my partner. I could share it with my religious guidance person. I could share it with my clinical team. But it's in the hands of the individual, and it helps the team in that moment of crisis. Of course, we have some resources on crisis planning, so I just want you to know that those also exist. Thank you so much for coming. We have 1 minute for questions. A question before Brian comes?
Sounds good, yeah.
Any questions?
Well, we're going to be around for a few minutes.
Take up that minute to mention the SMART tool real quick. No. It's lunch.
Go ahead, Brian.
Now, I was just going to say thank you very much, Dr. Cohen, Dr. Browning, Dr. Cotes. And this is, it's always difficult to have a presentation on the last day right before lunch, but this is such an important topic. We really appreciate it. And also we appreciate talking about the importance of talking about that it's the two opinions in the room, the two experts, making sure that we're including the voice of the individual with lived experience. So, and I have to say, from the time that I was a resident and started doing psychopharmacology, we didn't really consider anybody else's opinion. We just thought we just jumped in, did what we needed to do, and jumped out. And it's so much nicer now to be able to bring in that voice of lived experience. So thank you very much.
Thank you so much.
And the SMI Advisor is a great tool.
Thanks,
We have been so happy with it, and the landing pages for Clozapine and long-acting injectables, very helpful. So thank you for all the work that you're doing. And we're going to go to lunch, but I wanted to let people know that we're going to have a presentation during lunch. And so if you can try and get back in about 30 minutes with your lunch, just don't eat loud so that you can hear the presentation.
Sorry.
Thank you.